Well, this month we're here at the Green Acres Tubing Hill in Lake Elmo. It's March, and you know what that means, only 4 more months of winter. As we look forward to spring break, basketball playoffs, and some monumental snowstorms, hopefully all the respiratory illnesses and crud that come along with the season will go away too. So let's have some fun as we look towards spring. So this month we're going to stop by Kent's Equipment Corner, hear from Cassie, our resident pediatric guru, check in at the news desk, and learn about one of our first responder agencies. So stay tuned, because here are the 3 things you need to know.
Hi, Kent Griffith from Regions EMS. Today I'm doing a segment called Kent's Equipment Corner. We'll be demoing new equipment as it's introduced into our EMS, into your EMS system. Today I'm going to be talking about a device called the Enhanced Pneumothorax Needle from H&H Medical. Currently, when we've done pre-hospital decompressions with a standard angiocath needle, we've had some problems that have been noticed. One of the big problems is when you take a regular angiocath and push it in, holding the catheter instead of the hub of the needle, sometimes what will happen is that needle will back out and now you're left with a hollow catheter that you're trying to push through intercostal muscle, and the device will kink. Secondly, the other problem that has happened is if you hold it correctly by the hub, push it in until you think you're in the pleural space and remove the needle, you don't have verification other than a rush of air if that happens. So you're left to wonder whether you're in the right space or not if nothing has happened. Hopefully the patient will change, but that may or may not happen. So you're left with a catheter in there that you hope is in the right place. If you are in the right place, you have a rush of air and everything's great, over time, a regular angiocath needle will tend to kink, even a 10-gauge needle like that, a 10-gauge catheter like that. So H&H has designed a catheter that overcomes some of these shortfalls. They use a 14-gauge integrated 3.5-inch needle and catheter with a hollow closed-end silet and spring-loaded safety tip, with a color indicator that shows when you're in the pleural space. So this device will be placed in the same place you would normally do a angiocath. Oh, come on now. Go in. There we go. So as you place it in, the hollow or the blue indicator will rise, and then when you're in the pleural space, it will fall back down, noting that you're in the pleural space. It has an integrated one-way valve that allows for air to escape and not be sucked back in. The great thing about this, it has a 2-year shelf life. While the cost is a little bit higher than our current 10-gauge needles, I think it's a great device that allows you to know where you are and work much more effectively. So that's it, H&H.
Next, let's go check in with Nurse Cassie for our profound Pediatric Pearl of the Month.
Oh, hey, howdy folks. Thanks for tuning in to this month's edition of Pediatric Pearls. I'm Nurse Cassie. I was just working on a little ditty for y'all. Tell me what you think. Nurse McDoofer cared for a babe who needed E-I-E-I-O. At first she panicked at the scene. E-I-E-I-O. There's a tibia here and a humerus there. This one small, that one small. What's the biggest bone of all? Nurse McDoofer drilled the femur. E-I-E-I-O. On that note, Today I want to spend a few minutes talking about easy insertion and establishment of IO, or as I have dubbed it, EIEIO in the pediatric population. Let me set the scene. You get the call for a pediatric cardiac arrest. As you arrive on scene, compressions are being performed by the BLS crew. You're up for establishing IO access. Stress level, 10. During your pit crew resuscitation, there tends to be a medic close to the leg of the patient. It's almost instinct to choose the tibia, but when it comes to a younger pediatric patient, specifically those that are preambulatory, the femur is the preferred spot. Why, you ask? Well, let's take a minute to think about it. Preambulatory kids are typically 12 to 18 months in age and younger, and their bones are obviously small. When we focus on the tibia, we're limiting ourselves to a very small target. But as suggested in the song, what's the biggest bone in the body? You guessed it, the femur. So let's talk about how we can identify the landmarks and then go step by step through the insertion process. So when you are looking at the pediatric patient, in this case an infant, what you're going to do is identify the patella. Once you've identified the patella, you're going to go one finger breadth up, and that is of their finger breadth, not your own. One up and one over. So you're looking for the nice flat spot of the femur there. The tricky thing about kids this small is it can be difficult to palpate the patella. So another thing that you can do is find the very distal part of the condyles of the femur. Once you've got those in between your fingers, you're going to go about 3 of their finger breadths up and right in the center. So once I've identified my landmark and I'm PPE'd, I'm going to at first clean the site, and I'm going to hold that spot in between my fingers. I will then attach the needle to my drill. And most kids, we've learned that you can do pink as peds. If you're not going in the tibia on a very small child, I suggest starting with the blue needle. It's better to be too long than too short. So at first what we're going to do is poke into the baby until we can feel the bone. We've tapped that bone, make sure we're where we need to be. Once I've done that, I'm going to start drilling. And once I feel that release through the bone, I'm going to stop. Notice how I didn't pull back my arm right away when I felt that pop go through. Instead, I just lifted my finger off the trigger. I want to make sure that I'm not pulling the needle back out. So once I'm in, I'm going to stabilize the needle. I'm going to remove the stylet and place that in my sharps container. And then I'm going to grab my dressing. And you'll notice that these do telescope out. So if it is sticking out a little bit too far, that's okay. You're going to place your fingers over and you're going to press down until you hear a snap. And then you can take the tags off on either side to stabilize. If you don't have a tegaderm or a dressing like this, you can also use gauzes on either side to tape around it to keep it stabilized. So then I will attach my flush that has been pre-filled with my epidose. In this case, I'm using normal saline. And I will attach my flush. You can try to aspirate, but you won't always get blood back, so then we would flush our medication and lock. Once you've established your IO axis, some things that you want to keep in mind is that you want to stabilize the leg in place to make sure that it does not bend and potentially remove the needle from the site. When you're working on a cardiac arrest, any medication that you would normally put IV, you can use in your IO. Also, when you are doing fluid resuscitation through an IO, in the femur, you will need pressure behind it. So a couple things that you could do would either be able to put a pressure bag on, or in the pediatric patient, because it is such a small amount of fluid that they need, we can manually insert that using a larger syringe and push that in. Other things to think about, You want to watch for extravasation to the site itself. So we'll look for blanching or swelling beneath or posterior to where the needle has been inserted. So don't panic if you don't get it in the femur the first time. You still have other places to go on the pediatric patient. Again, we can use the proximal tibia, the distal tibia, and the head of the humerus. But the femur, remember, it's the biggest bone in the body, so it's the biggest target that you have available to you. So now you know, and next time you have to EIEIO, there's no worries. Thanks for tuning in.
Hello, I'm Dr. Peterson, and this is a Regions EMS update. ECMO, ECMO, ECMO. Are you sick of hearing about ECMO yet? I hope not, because this is one of the most exciting things to happen to cardiac arrest since the invention of the defibrillator. The East Metro is providing a large proportion of the ECMO patients, so keep up the good work. The success of this program, and therefore the survival of the patients, is really driven by EMS more than anything else. So to refresh you, here is a phone number to call and the ECMO inclusion criteria again. We've had enough cases now to identify what's going well and what's not going so well. Here are a few things to keep in mind. The ECMO doc wants to talk to you. If you're not sure whether or not the patient qualifies, call the ECMO doc and let them decide. Speed is of the essence. Have a sense of urgency if the first rhythm is shockable. In fact, think of these things as ECMO detectors. If you're a first responder, give the ambulance a heads up if you shock the patient, and then be ready to load and go right away. If Sparky says shock it, start moving like a rocket. I just made that one up. You're welcome. We're also working with the ECMO team to make sure that you get some good follow-up on anyone for whom you activate the team. Please feel free to reach out to your clinical supervisor if you're looking for information. Next up, let's talk about the coronavirus situation. It actually has a name now, COVID-19. Not much has changed locally, still no cases in Minnesota. The 911 dispatch centers in Ramsey, Washington, and St. Croix counties are all asking additional screening questions, so hopefully you would get a heads up if something sneaks into our area. The two main things to keep in mind are to avoid any aerosol generating procedures like nebulizers, and don't skimp on your PPE. Before making patient contact, you should be wearing a disposable gown, an N95 mask, a face shield, and of course, gloves. You should also put a mask on the patient, but remember they don't get the N95s. A standard surgical or filter mask is fine. Other than that, no change in daily operations, but we will definitely keep you posted if the situation changes. And finally, let's just acknowledge that we're heading into a time of year when we typically see a spike in suicide attempts. No one likes to bring this up, but sometimes we see things that no one should have to see. The stress of the job, the stress of the schedule, the stress of life can sometimes feel overwhelming. We all need to have healthy ways to debrief after difficult calls and burn off stress. We talked about this in several videos throughout 2018, so know that there are resources out there to help you cope.
All of us have to manage and deal with the stress of our emergency service job.
Our field is not a mathematical equation. We can do every single thing right, and the patient still dies.
That's all the news I have for now. Let's send you back to your regularly scheduled programming. So let's head over to Lake Elmo Fire, one of our education customers and a first responding agency for Lakeview EMS. I wonder if anyone will be home. So we're out with the Lake Elmo Fire Chief Mike Cornell. His department serves a city of about 10,000 people. Mike, tell us a little bit about the Lake Elmo Fire Department.
We are a department that runs about 539 calls. We have 22 members. We're also a combination department. We have part-timers during the day and our paid on calls cover at night.
Any interesting calls lately?
The most interesting one is we had a chicken coop fire where we saved some chickens.
Well played. I'll bet that was a nice little barbecue dinner after that.
Yeah, yep.
Any other unique features of the city that you respond to?
Well, we have Washington County's largest regional park, the Lake Elmo Park Reserve. During the summer, it brings in about 5,000 people on a weekend. So we got a bunch of people coming into our city that normally is not here.
Sure. Do you ever respond to Green Acres?
Oh yes, love that place.
Well, I live in the city of Lake Elmo, so this department is very near and dear to my heart. So thanks for being a partner with us.
Well, thank you.
Well, that's a wrap for this month. Be sure to check us out on social media and be on the lookout for some new podcast episodes that will be debuting soon. Thanks for watching, and until next month, be smart, be safe, and be professional. Hey Chief, you know Christmas is over. You might want to get rid of that wreath now.